Hello everyone, this is Dr. Abeer Hasan Sharaffuddin from Yemen, periodontist and dental implantologist, PhD, Cairo University. Firstly, I want to thank Dr. Mazen Dauman for this invitation, and I'm really happy to be with all of you today. I'm going to present a particular subject which is about furcation involvement. I actually chose this kind of presentation because I didn't find enough shed light about this issue. And also, we are facing a lot of cases with furcation defects in the entire practical day. Therefore, we had to know some principles in order to know how to master such cases. I will highlight some points like introduction, anatomy of multirooted teeth, classifications of furcation involvement, etiology, diagnosis, and treatment. The definition of furcation involvement is already known as a condition in which the bifurcations and trifurcations teeth are invaded by periodontal diseases, characterized by bone resorption and loss of attachment. So, what is the exactly meaning of the term furcation? It comes from furca, which is a Latin word, means several projections coming from one structure or one stream, as I illustrated in these pictures. Basically, the first step to know more about furcation defect is the importance to know about the anatomy of multirooted teeth. Root complex means all parts of the root, from cemento enamel junction to the apex of the root. Root complex has two parts, non-divided part, which is the trunk, from cemento enamel junction to the separator area, and divided part from the furcation entrance to the rest of the root cone. Root trunk could either be short trunk, which means long roots with good attachment and prognosis. The tooth will be survived and stable with minimum amount of infection. The long trunk attachment means infection will invade a large amount of soft and hard tissue, which is very difficult to manage it. Poor prognosis due to weak attachment. By the way, maxillary molars have long trunk more than mandible. Furcation entrance, it's a transitional area between the undivided and divided part, which is making a lot of problems during mechanical instrumentation. 81% of molars with furcation entrance less than 0.75. Buccal furcation of maxillary molars presented the highest frequencies of entrance, narrower than 0.8 millimeter. The blade width of curettes was reported to be limited during furcation debridement. Fornix, which is the roof of the furcation. The most difference between fornix and entrance is the entrance is starting point of furcation and trifurcation area, while the fornix is the most coronal surface from the root separation. Local developmental anomalies, which are the predisposing factors, not the etiological factors in the first place. Enamel pairs. Enamel pairs are isolated ectopic enamel nodules connected to cementum or root dentine. It may consist entirely of enamel or may contain a core of dentine without extension of pulp tissue. They contribute to the etiology of furcation involvement by preventing periodontal tissue attachment. Cemento enamel projection is an anatomical variation that represents an extension of the cervical enamel from the cemento enamel junction, either toward or into the root furcation area. The presence of cemento enamel projection could enhance plaque biofilm retention, and it could be 3 grades according to their extension towards furcation. Root concavities, which are also predisposing factors. Presence of root depressions could complicate the prognosis of teeth with furcation involvement. These concavities are potential sites for plaque retention once periodontal destruction has occurred and predisposed to incomplete root surface debridement. Therefore, the combination of hand instruments, sonic and ultrasonic scalars may be more efficient in debridement of furcation areas. From the city of Sant Mario, this paper was produced, in which I recommend to know more about the morphometric features of multirooted teeth. Not only dental anomalies could be the definitive causative factors of furcation involvement. For sure, there are a lot of causative factors like microbial dental plaque and consuming the endogenous nutrients like salivary proteins and glycoproteins. I mean also the endoperio or perio-endo lesions, they associated with a huge variations of anaerobic bacteria, especially when the necrotic bulb has a long time with no treatment. When there is traumatic occlusion associated with inflammatory process, the furcation involvement is much predictable, lead to bone loss and mobility. At the same line, it's really important for me to differentiate the secondary traumatic occlusion from the primary one. So the primary is a traumatic process from improper occlusion without inflammation, but with secondary traumatic occlusion, it's associated with inflammation, lead to a clinical attachment loss. Okay. The root trunk length, I explained this point previously. The point of short trunk have early involvement in disease, which is the opposite of the long trunk. It takes a long time to reach the furcation involvement, but difficult for the instruments to reach the furcation area. Classification of furcation involvement. Over the time, there were many classifications for furcation defect. Some of them are still in circulation of evidence base, and some of them have drifted and no longer have a great reference value. So we need an obvious and simple classification in order to obtain the right diagnosis. In 2018, University of Bulgaria published this literature review. They mentioned all classifications, ancient and the most recent one. I want to focus attention on the most familiar classifications, either vertical or horizontal furcation defect evaluation. Glickman's classification, which is a horizontal evaluation for the defect. Grade 1 is an early stage and incipient furcation, no radiographic evidence for bone loss. Grade 2, cul-de-sac with a horizontal component, pocket formation, and loss of interradicular bone, but not through and through. Grade 3, communicating or through and through furcation, defect filled with soft tissue, and some triangular radiolucency can be detected in radiographic evidence, but in maxilla sometimes could be difficult because the palatal root overlapping the maxillary molars. In grade 4, interradicular bone is completely destroyed and the soft tissue recede apically, so the furcation opening is seen clinically. Turnau and Fletcher in 1984, based on vertical component of furcation area, measure the distance between fornix to the alveolar bone of the adjacent two roots, grade A from 1 to 3 mm, grade B from 4 to 6 mm, grade C more than 6 mm. In 2018, from Sapienza, University of Rome, Dr. Andrea Pollini published this new classification of furcation defect. Dr. Pollini proposed classification system for furcation lesions. He described two main features in furcation defect, whether non-exposed or exposed. Okay, before I go through the paper itself, I have to know how can I use the Napiers probe, or sometimes they called it as an advanced composition explorer, which is ACE.
Hi, I'm Wendy Birtles, RDH, and this is our Advanced Comprehensive Exam, or ACE, probe. With the ACE probe, you can do more accurate and faster periodontal probing because you have a thin, flexible furcation probe on one end and a straight probe on the other. The thin, flexible furcation probe will ensure you have more accurate readings even in areas where access to furcations may be difficult. The benefit of having the straight probe on the opposite end means you can save time and switch ends rather than instruments for each furcation. Having more accurate readings during periodontal probing and knowing if the furcation is class 1, 2, or 3 is essential for considering a tooth for regeneration or extraction. The curved end of the ACE probe allows you to determine class 1, 2, or 3 furcations because it has 3, 6, and 9 millimeter markings. The straight probe end is available with UNC 12 millimeter markings, UNC 15 millimeter markings, or as a probe 12 with 3, 6, and 9 millimeter markings.
Turn back to Dr. Pollini classification. Firstly, we have the non-exposed, which is clinically non-exposed furcation lesion. Class 1 incipient lesion, horizontal attachment loss of 2 millimeter or less. A class 2 horizontal attachment loss of 3 millimeter or more. Class 3 total horizontal attachment loss through and through. Imagine that we are in the clinic and we have furcation involvement, which is class 1. It's here non-exposed, and the neighbor's probe can go through the furcation involvement about 2 millimeter or sometimes less. And class 2, the neighbor's probe can go through the furcation involvement more than 3 millimeter and not through and through. But we have class 3, it's still non-exposed, but the neighbor probe can go through the furcation involvement through and through, which is communicated defects. Again, imagine that we are in the clinic. So we can find here the furcation involvement in the first picture, which is incipient. And the neighbor probe can go through the furcation involvement about 2 millimeter or sometimes less. Class 2, which is more than 2 millimeter, sometimes 3 or 4, and the furcation involvement class 3, which is through and already exposed clinically. Recession without furcation exposure, it considers that non-exposed furcation involvement. Let me ask you one question. Should we treat and fix the furcation defect? Is it utterly important to regenerate the defected area? In other words, does it work and have a good prognosis? Actually, the answer is yes. To reduce from class 2 to a class 1 furcation involvement in order to improve the long-term prognosis. Also, molars with class 1 furcation were lost in 10% of the cases at 12 years, while at 10 years, molars with class 2 and class 3 were lost in 25% and 40% of the cases, respectively. And most molars affected by furcation involvement respond well to periodontal treatment, and even in the presence of degree 3 furcation, only 30% of molars were lost in follow-up period of 5 to 15 years. The American Association of Periodontology published this paper in 2015 to answer this question: how should periodontal furcation defects be managed by a periodontal regenerative therapy, and what parameters should be used for treatment selection? The most important factors that we have to mention first are the patient factors resembling in systemic diseases like diabetes, obesity, and immunocompromised patients. Also, behavioral, when the patient is smoking more than 10 cigarettes daily, the bad oral hygiene, and patient compliance. Anatomic and site factors like access to surgical site, interproximal bone height relative to furcation, root trunk length, root concavities, and grooves. I think these points, we talked about them previously, and root proximity, convergence, furcation entrance width, furcation defect depth, and cervical enamel projections and enamel pairs. tooth mobility, periodontal phenotype, width of tissue, keratinized tissue, and assessment of endodontic status, proximity of restorations to furcation entrance. An important point we have to highlight and focus on, which is the grade of furcation involvement. I mean, different grade has a different scenario during the clinical treatment. I mean, in grade one, it doesn't need regenerative materials, so it's going to be a successful treatment with subgingival debridement. In class 2, furcation defects are the most predictable to obtain furcation closure via regenerative materials, while the class 3 defect will respond with gain, but it's going to be a histological gain, not a closure or furcation closure. Patient compliance has a major role in the treatment success. All the previous factors are relating to the patient behavior and to the instructions that's supposed to be applied. In Brazil, in 2021, a recent paper published, which is about the effect or the effects of patient compliance in supportive periodontal therapy on tooth loss. It was a systematic review and meta-analysis. The first plot is revealing the results of patient compliance in the teeth loss. All studies showed a statistically significant effect in the favor of non-compliance to supportive periodontal therapy. Now, how we can treat the furcation involvement? Which is the most effective treatment in such cases? Should we choose the scaling and subgingival debridement, regeneration, or extraction? I think we have to collect and gather all these treatment techniques in order to obtain a good result. The first kind of treatment is the non-surgical periodontal treatment, which is the scaling and subgingival debridement, or sometimes we call it the deep subgingival debridement. Regarding the grade 1 furcation defects, sometimes no interradicular bone involvement, insufficient to establish stable periodontal conditions, and it's associated with survival rates that may reach 100% after 5 years and 78% after 10 to 20 years. Grade 2 and grade 3 furcation defects, yes, they can include it in the subgingival debridement or the non-surgical treatment. Partially and completed interradicular bone destruction. So the survival rates of molars with grade 2 and 3 with subgingival debridement were 83.5% and 59.8%. Most of molars affected by furcation involvement respond well to periodontal treatment, and even in the presence of degree 3 furcation, only 30% of molars were lost in follow-up period of from 5 to 15 years. Secondly, the surgical periodontal treatment. We can sum up the meaning of regeneration by using the word PAS. P, which is referring to the principal wound healing, A to the angiogenesis, which is the formation of new blood vessels, S, the space, and the other S, it's the stability of the regenerative material or stability of the blood clot or the membrane. To expand our knowledge about PAS from the University of Michigan, I chose a very interesting paper from Dr. Wang titled with PAS Principles of Predictable Bone Regeneration. You can download this paper and you can get some information that can help you to understand more about PAS and about bone regeneration. Returned back to Germany with Dr. Anton Skolian and his team, with their distinguished paper, which is about the clinical concepts in the regenerative periodontal therapy. In fact, they published this paper in 2017 and they highlighted different treatment techniques in regenerative therapy in the Furcation involvement. The medical term of regeneration has two parts to speak in. The first one, which is the guided tissue regeneration, which is a method used to repair the periodontal defects. So that tooth or teeth has more support and stability. These gaps or bony defects often need to be treated with a separate procedure known as bone graft. This is where material is placed into the defect to promote new bone growth. While the guided bone regeneration is related to the implant, we are increasing the width of the alveolar bone or the alveolar ridge in order to create the suitable place of the dental implant. Anton Skolniak created this table, which is about the decision tree for regenerative therapy in Furcation defects. In class 1, I can do only scaling and root planning, or I can say scaling and deep subgingival debridement. In class 2, I have two kinds of Furcation defects. The interproximal bone level could be below the Furcation entrance, and the second one, the interproximal bone level, could be coronal to Furcation entrance. When the bone level below the Furcation entrance, I can go through the resective surgery like apically positioned flap, tunnel, root amputation, or bimesection. In the kinds of in the defect, while the bone level coronal to Furcation entrance, I can go through regenerative therapy using grafting materials and membrane. In class 3, I have two kinds of techniques or treatment like resective therapy or extraction. All these criteria, I'm going to explain it in the further slides. As I mentioned in class 1, some papers reported that I can do open flap debridement, or it can be maintained successfully by non-surgical means, whereas deeper defect required surgery. In class 2, when I have interproximal bone level coronal to Furcation entrance, I mean here the smile face. So here I need to make a surgical mechanical debridement or open flap debridement, which is, it depends on the severity of the case. If it needs surgical debridement or needs deep subgingival debridement. Another picture to class 2, when the interproximal bone level coronal to Furcation entrance, I can see here in the radiograph, which is clearly obvious, the interproximal bone coronal to the Furcation involvement here. So the regenerative procedure is going to be easier and very, very successful. In class 2, when the interproximal bone superior or above the Furcation involvement, the combination therapy is going to be a good solution. I can use the grafted materials only without barriers like xenografts or autogenous graft. Could be used if there is an exostosis at the same quadrant. Also, allogenic graft could be used. Emdogaine has a good consequences. I can use it alone or with combination with bone and membrane. In a condition of the sad face, I mean when the interproximal bone is below or the same level of the Furcation involvement. Here is the importance of radiograph. I can detect the bone level without X-ray. The regenerative procedures is not indicated and bone growth is not predictable. The treatment of Furcation defect when the proximal bone became below or at the same level of Furcation involvement is odontoplasty and tunneling, which is preparing the Furcation area properly in order to clean the defect side by the patient using interdental brush and maintain a soft tissue healthy. Hemisectioning is one of the most effective techniques in case of interproximal bone loss and regeneration is not predictable. Using this approach to remove the most deteriorated root with a good endodontic therapy and keep the healthy root with a good restoration. The second procedure is the bicusbidazation, which is a surgical procedure performed with the mandibular molars for the separation of the mesial and distal roots with their respective crown portions. The separation eliminates the existence of furcation and facilitates effective oral hygiene practice. University of Yogyakarta published this case report, which is about bicusbidazation of a mandibular first molar with furcation defect. By the way, the city of Yogyakarta is a region in Indonesia. Bicusbidazation was performed 1 month after endodontic treatment, with full thickness flap extending from lower 5 to lower 7. Then the tooth was separated vertically into mesial and distal portions. And then grafted material and membrane were placed. Flap repositioned and sutures performed for 10 to 14 days. After 2 months, porcelain fused to metal crowns were placed for 2 portions as separated teeth. So, how we can manage the cases and the conditions of class 3 in the cases of severe bone loss? In class 3, we can do everything. It depends on the severity of the case. We can do bicusbidazation, we can do tunneling, and even extraction. We can do also the non-surgical treatment like scaling and root planning or scaling and subgingival debridement. Okay. Finally, Anton Skolnian recommended some points regarding to maxillary and mandibular molars class 2 furcation involvement. Firstly, robust evidence showing that regenerative therapy generally yields to superior outcomes as compared with conventional subgingival debridement. From the histological concept, the evidence of complete periodontal regeneration is very obvious after application of regenerative approach. In the class 3 furcation involvement, regarding to maxillary and mandibular molars, the regenerative therapy could be indicated. But in lower molars, there is an evidence of complete periodontal regeneration after application regenerative approach. Now, Dr. Cortellini is going to perform a surgical procedure to lower molars showing the regenerative approach using bone and membrane in the furcation defect. Have a nice time.
Lower right molar presenting with a degree 2 furcation 5 mm deep. The radiograph shows the furcation involvement and the mesial and distal bone peaks. An intracircular incision is traced with a microblade to allow for the elevation of a full thickness buccal flap. The incision will be extended to the mesial and the distal papillae. A periosteal elevator is now reflecting a full thickness buccal flap. The bone crest is exposed as well as the furcation entrance. The granulation tissue is removed with curettes and the root surfaces carefully debrided with the combined application of mechanical and hand instruments. A fine-grained diamond tip is applied to eliminate calculus, concavities, and enamel projections from the furcation. Measurements are taken to determine the size of the guidor matrix barrier. And the mesial and distal papillae de-epithelialized with a scalpel and microschissos. Measurements taken on the furcation entrance are reported on the guidon matrix barrier. The barrier is shaped in the vertical and horizontal dimension to fit the buccal side of the molar. The collar is partly trimmed to remove the ligature and allow for the elimination of the exceeding material. The corners are also rounded to reduce the impact on the soft tissues. The flap is now further extended with the periosteal elevator to gain enough space for membrane allocation. The membrane is positioned under the flap. The ligature passed through the interdental spaces and tightened on the lingual side. The barrier is now lifted and some bovine bone mineral is placed within the furcation. The material has to completely fill the furcation area. The barrier is then repositioned and carefully adapted under the buccal flap. The periosteum is fenestrated with a number 15 blade. Ample mobility of the flap is necessary for the coronal advancement and the protection of the barrier. The flap is coronally advanced with a sling suture, catching the mesial aspect of the flap through the interdental spaces, catching the distal aspect of the flap, back to lingual, back to buccal, to be tightened with 3 single counter knots. The flap is now coronally positioned to cover the barrier, and the mesial and the distal papillae are stabilized with passing sutures through the interdental space. At the end of the procedure, the flap is coronally advanced to the cement-enamel junction and completely covers the barrier. At 1 week, the gingival margin is stable. At 1 year, we observe the expected gingival retraction. The 1-year radiograph shows bone formation in the furcation area.
Finally, furcation involvement results due to multifactorial causes. Case selection is the key of treatment success. Whether you are periodontist or not, getting the basics in every dentistry branches is mandatory to level up your practicing. At the end of my presentation, I really enjoyed speaking to all of you and hope to get benefit from this lecture. Try to create your own stage even if you are not a doctor. Creativity is relating to your existence as a human being, so you certainly have something to show to the world. Be yourself and enjoy your life.